Do this. Right, I think we're live. Hi there, how are you doing?
I'm good, thank you, Andy. How are you?
Excellent. Well, doing well, thank you, this fine evening. Our first streaming session now. This is going to be entertaining. And if anybody's joining us live, please just say hi in the comment section and let us know what part of the world are you from, which would be brilliant. We're open to questions, but we've got different cases and things and questions for Javier as we go along, and we'll see how we get on, shan't we? So, Javier, before I get my first case up for you to look at, because you've not seen these, have you?
Nope.
And you didn't know this was a test, did you?
I'm about to say you're going to show my ignorance online.
Well, no, if you fail, you have got to bring me coffee.
Sadly, not the first time I've seen your foot.
Oh, I know. Or a bit of pizza. Bring me pizza, one or the other. Are you ready?
Can I convert it with the audience then, if I'm unsure?
You can confer with the audience. That's fine. So first of all, just briefly say, who are you, Javier? Because they probably know me as GP.
Yeah.
Tell me a bit about who are you.
So I'm a salary GP in UK, quite new. I'm 1 year kind of since properly fully qualifying. I worked with Andy during my training. He wasn't my direct supervisor, but nice practice, got to know everyone. And Andy kind of infected me with the idea that dermoscopy could be done easily. But it seems to have stuck, and I carry it on. And Andy's been very kind and sort of mentored me. You know, you've been a sounding board for when I've kind of been or just needed someone's expert wisdom, someone a bit older and wiser than myself.
Yeah. So, anybody who's keen in dermoscopy, happy to help. And Javier was rather keen, so happy to encourage you along the way. Right, let's get that first case up. So have a little look at this. This is a guy. It's going to be a little bit of a video. I'll just I'm going to share screen. Let's go through. So he's about 70, and he came up because his wife was concerned. This is going to be a video, and when you watch the video, oh, where's it gone? There we go. Let me get rid of that. And let me do this. So we're just testing out the technology as well, folks. So add stage, remove. There we go. That should, no, why is it not adding what I want?
You're still ahead of me. I'm about to say, you've got this live stream on YouTube. That's still
yeah,
ahead of my my IT skills.
Well, what we've got here, if I try it again, there we go. Share screen, good. Window, right window, here we go. Share, you should see it now. Perfect. There we go. Right, so this is a guy, he's kind of like in his 70s, and have a look at his back. Look at that. And what do you think of this here? What do you reckon?
I think initially I thought, looks a bit like a Seb K. I must admit, it's quite small on my screen, so I'm keen to see what we see dermoscopically.
Run it forward a little bit. I'll give you the dermoscopy in a little bit, but it's quite big, isn't it? Look at that.
And it's got a bit of a, two shades of color and kind of two.
Yeah. Yeah. So here's the dermoscopy coming up. You got to bear in mind that these are kind of like sort of unedited in that, you get a bit of everything really. Here we go.
What's the story? Oh, okay.
So the story, his wife, he's had it a few years, and it gradually got bigger. What do you think of that at the periphery? What's your thinking on that?
I mean, it's kind of a bit slightly ash leaf, almost that kind of Igo look to it. It looks like a clear border.
Yeah.
The pigment looks okay, and is that we can see quite a lot of. I guess you've got your milieu and things, so I mean that's a reassuring feature. So
I think of that. If anybody wants to put in the comments what they think, that's great. But go on, yeah.
I mean, I'm sure the audience is sharper than me, but I would be quite comfortable asking you and confirming with you.
Okay,
Andy,
so the key question is and one of the first things I had to learn was the difference between fissures and ridges pattern and a network pattern, pigment network pattern, because one is melanocytic in origin and one it usually goes with the SEB-K, and that's really critical. So what do you think this is?
I think of kind of the non-melo, Subaru 2305s on the SEB-K team as well. So what did you say? SEB-Ks are more fissures and ridges?
Oh yeah, fissures and ridges.
I think this fits quite characteristically with fissures and ridges.
Okay. Anything here to suggest a melanoma, do you think?
I can't see any kind of shiny white structures.
Yeah. What do you think of this here?
I think that's just a lot of kind of like with the sebum, and it's a lot of from the macroscopic picture, that's kind of the elevated part of the SEB-K. Yeah,
we've got a comment. Someone thinks it's SEB-K. Excellent, thank you. I think with all these things in general practice, the thing I always think is, is this, am I willing to bet my career on this?
Yeah.
When you start off, you see something big like that, and you slap your dermoscope on it, and there's all sorts of colours and things. So, and when early on, I would look at something like this in the middle here, and I would think, is that a blue-white veil?
No. And looking at that now, I could definitely see that argument.
So periphery, really well circumscribed. You've got these nice fissures and ridges. But so what's going on in here then? What do you think?
So is it possible to zoom in a bit on it?
I can't zoom in on that bit, but what I'll do is I'll do this for you. I will bring you up a picture which you can zoom in on, because that's works well. Let's just bring that up there. Let's do that. There we go.
And so the story was, wife noticed it, no change from his kind of concerns.
Just gradually getting larger. I mean, for me, this is fissures and ridges pattern, but you can always get a collision, can't you?
That's true. Yeah.
So a collision is something that you always worry about.
Yeah, and I think with now that you're looking at it, you do wonder, especially there, this kind of is slightly higher up. Is that a bit of a blue-white veil? I guess there's just kind of these comedome like openings and things which I've not really seen with kind of melanomas, but
okay. So having a look at this is very much more thickened. So if you remember, on my video I did CHAP, cysts, hyperkeratotic, acanthotic, and acanthosis is a thickening. So often, I mean, the early bit here, this is all flat, but as it rises up, you get these deeper fissures and ridges. And it gets thickened, and often you get this purpley color with all this melanin mixed in it. So it's melanotic, but it's not melanocytic. In other words, no melanocytes involved in this.
Right.
And this is almost a cerebriform pattern. Or you could almost say that, couldn't you? And with this blue hit here, these dots here, almost frog spawny really there.
Okay. Yeah.
So I looked at that and I decided that I wasn't going to worry about it.
Okay.
Rightly or wrongly. And so I've actually just reassured him. And then I looked through his notes, and a consultant had seen him about 5 years ago, and it was much smaller, but they said, oh yeah, it's a SEB-K.
Okay.
So that kind of like reassured me. So very often I would, give him advice, but looking across his back, they were just all SEB-Ks. And this was a very odd, unusual one, just like a fried egg almost. But look how beautiful, the edges all the way around. Look at that. That's almost scalloped, isn't it? And with pigment network, it just blends out just that little bit more.
So, in this image, what do you kind of transcribe that kind of veiling type effect to?
So it's due to thick keratin overlying melanin. And in one sense, it is a blue-white veil. It's just not a melanoma. And that's the thing. So you can get kind of like a bluish-white veil over some capillary hemangiomas, but then you've got the lacunes.
Yeah.
So a lot of how you interpret the colours is based on the other things that you see.
Whole picture.
And of all our other criteria for a melanoma or a melanocytic lesion, there was nothing else in here. And if you looked, when I look carefully at the video, there are a few milia that flash up as well. But then
and then you show that. So that's why I wasn't. I think that was the thing that kind of would put my mind at ease. I think it's quite cool with your dermoscope how you can go in with the blue light. It just.
So before I get on the next one, that's case one. If anyone's got any questions about that or disagrees with me, please let me know. What are you most enjoying about dermoscopy then, Javier, at the moment? You know, what are you enjoying?
I think I'm quite a lazy person, I think, at times. So I think I enjoy the quick wins. So it's really nice when I've got colleagues kind of coming to me being like, oh, we've just got this lesion. Can you have a quick look? I'm a bit worried. And you know, as you've just heard me say and kind of explain myself, that clearly I'm not an expert by any means, but I've got some understanding of kind of some of the basics. So, you know, some really obvious hemangiomas can look horrific, you know, macroscopic. Have a look and go, I'm not worried. I had one on the face that was like a sebaceous hyperplasia. Like characteristic sebaceous hyperplasia. And because I'm still quite new, sometimes for my own kind of reassurance, I might bring them back in maybe 6 to 8 weeks time. And then just have a look at it, take another image. So I'm still learning in that sense, but I think that's the biggest win. It's quick and easy. And, you know,
it is the first one I ever saw, capillary hemangioma, and I thought, oh, it's not a melanoma. And those are the quick wins, aren't they? Because they're dark and black, and you think, oh dear, is it a nodular melanoma? And then you look at it and you think, oh, no, it's not. And it's great to reassure them. And when your colleagues come, right, have a look at this. This is a guy, again, you know, kind of like early 70s, and his dentist had seen this. You know, a dentist had seen this thing. So you got this little, and this is a bit of video. The lighting's not brilliant on this, but you can get an idea of it. You kind of like got this bluish sort of plaque there, and then you've got this brown extension coming down it, which kind of like always worried me. You know, with melanomas, you'll often get a little bit of pigment, which kind of like works its way down. So, you know, you can kind of like see that kind of like that little plaque on the side. And that had only been there about 3 or 4 months that he'd noticed. So it's relatively new. And if you look at that without a dermoscope, you're thinking, am I 100% sure that that's nothing to worry about, you know? So let's get into the dermoscopy then. That's it. There we go. Let's get the jelly on. Get the jelly on. Get the jelly on so you can switch between polarized and non-polarized. Okay, right. So that's the upper bit. What do you think of that upper bit?
Okay, so it's a very nice amount of milia up there.
Yeah. So look, you've got all these little dots, haven't you? So that's that's non-polarized light, and then boom, where have they gone? You know, and you've got these early fissures and ridges here, and you know, so that instantly, where you see that number of milli, you're thinking this is a bit of a SEB-K in there, isn't it? And look at all that, you know, blue, light blue coming up on the ultraviolet light. And I'm starting to like the ultraviolet light for SEB-Ks. I mean, just look at that shine up there. So you think, okay, that pink bit at the top, I can't see anything melanocytic. There's a few little vessels in there, isn't there? A few little dots and things, maybe fissures and ridges forming here. Reasonable edge to it, maybe a bit indistinct here, but nothing there that screams at me anything other than SEB-K. So, and yet, the thing is, you always can get these collisions.
Sure.
So let's go down and let's have a little look at the other one. Here we go. Again, a murky sort of brown, darker bit here, isn't there? But you've got these little white bits here, maybe. Let's see if I click the button. Nope. There you go. Looks like a teardrop, doesn't it?
Yeah.
And you can kind of like see, you can see the milia lighting up there, can't you? A comedo-like opening there, homogeneous pink background. The edge isn't very clear, you know, but you've got all the milia up here, you know, you've got maybe fissures and ridges pattern here. So again, you slap your dermoscope on that and you think, it's just a SEB-K. Do not pass go home. Don't worry, your dentist told you nothing to worry about. But without a dermoscope, you do start to worry about these things, don't you?
Just on that note, so, you know, I think when you switch the infrared and things, it's really easy to see the milia. Is there ever a case where on the dermoscope...
the comedone-like openings, it's the keratin surface.
Sorry, yeah, the comedone-like openings.
Yeah.
So, is there ever a time where you might see comedone-like openings and still be worried?
Comedone-like openings. if they are comedone-like openings, and there's lots of them, you're reassured. But you always take it in consideration for everything. So you put all the pieces. It's a jigsaw puzzle, isn't it? The history, past history, what else is around it, what type of skin there is. If you already got comedones and things that go with Seb K, then usually you're pretty happy.
Yeah.
So what sort of dermoscopy have you got, Javier? What you're using?
The Ibulu.
Oh, right, okay.
I believe you've done a review on one of your channels.
How are you finding it? Are you getting used to it?
Yeah, I'm going to put my hands up and say I was a bit of a rookie initially, and getting in focus pictures was probably something I wasn't great at, and that makes a world of difference.
Yeah.
So, yeah, it takes.
Okay. Yeah, I mean, I remember when you started, you weren't so sure about the polarized, non-polarized, were you?
Sure. Yeah.
So learning to put the jelly on and switch between the two to get that stars and night sky is important, isn't it? Yeah. Right. Okay. So this lady, she's kind of like 65, and if you have a little look at the color of her skin, she's got these brown marks. What are these brown marks?
Lentigos.
Yeah. So these will be solar lentigos. And then she's got this red nose, some red bits in here, and she was concerned about that there. Okay. Oh. So what sort of, let's go, because different parts of the skin have different types of dermoscopy. So what's the, so as soon as I see something on a bit of skin, I think, what's the type of skin and what are the most likely things? So just looking at that, what do you think is the most likely cause for that?
Most likely sun damage, AK type.
And anybody watching this, please type in what you think. Go on, sorry.
So I think, betting man, sun damage, so an AK type.
Okay. Yep. Anything else? Zoom in.
Essentially, I mean, maybe not there, but things like rosacea.
Okay. Yeah. So you can just get a bit of inflammation, can't you? A bit of eczema and stuff like that. And you feel the surface of it. It's a little bit rough, and it's been there a few months, and she just doesn't like it. Looks a little bit unsightly for her. So let's start this dermoscope on it then, and let's see what we get. Let's see if I can. No. Yep. I'm learning how to do all the different bits and pieces to share. Here we go. It's got some little foibles. This. Here we go. So this is the dermoscopy of the nose. Let me zoom in a bit. What do you reckon?
It's quite tricky to say, I think. I mean, my eyesight's not as sharp as it used to be. I'm not seeing clear kind of vessels as such to indicate kind of superficial BCC or anything like that. So possible to zoom in any more on that bit? Is that a bit of sebum there?
What's this here? What are these things here?
Is that sebum? Oh, no, sorry. That's a rosette sign.
It's a nice little rosette. Yeah. So, you can get, and I have seen BCCs on the nose like that. It's only when you slap the dermoscope on, do you then get something like this, which is a nice bit of grade 1, maybe 2, actinic keratosis. Grade 2. Grade 1, you can feel more than see. Grade 2, you can see and feel. And she's got the rosettes, the strawberry pattern, really. So, for her, it was a matter of, do you really need treating? Get your sun cream on there. But, we can, at least we know what we're doing now with the dermoscope. We know how we're going to treat it. This is sun damage, madam. You've got a couple of other little patches. You've got that type of skin. Yeah, you're at risk of skin cancer. I think I gave her some imicrimode. I can't remember. I think she really wanted it treating. And that was key, really.
I mean, I tend to always, if it's, quite mild AK, and I think, I don't think I need to be too hard. What's your kind of take?
On?
Solar rays. So diclofenac gel.
I don't like solar rays. It's supposed to be 50-50. I tend to, men with bad scalps, bold scalps, I tend to use solar rays when I don't really want to treat it. Do you know what I mean?
Sure,
when it's very mild. And I do have some, because you have to use it twice a day for 10 weeks.
Yeah.
So I sometimes, I only use it on mild stuff.
Yes, yeah.
And stuff where I think I don't really want to treat it, but they want to treat it. Let's give it a go for 10 weeks. And if you're unhappy, come back and we'll give you something else kind of thing.
Because I think for her, that's probably what I probably would have opted for. As you mentioned, it looks...
No, you could do, yeah. I entirely agree. You could go for some solar rays, yeah. But the sun protection, over 12 months, about 1 in 3 of those AKs will go away. So, your sun protection is very important.
Right.
Yeah. Right, next one for you then. Let's have a little look at this. So this is a bit of video. This is an interesting one. This is I looked at him and he had something else going on, which I referred him for. But this was on his forehead. He's not had any skin cancers before. And I was just having a look around like you do. Birds of a feather flock together. And he's got this thing on his forehead. What do you think of that?
I think it could be sebaceous hyperplasia from what, but again, look forward to seeing our...
Yeah, sebaceous hyperplasia, very common on the forehead, indeed. Let's see, here we go.
Oh, okay.
Is that sebaceous gland hyperplasia, do you think? Everybody can chip in with a comment if they wish. Right, you've got to tell me what signs you see. So would you like, I'll go give you a picture, shall I? Let's give you a picture.
Let's do that and zoom in, and
maybe I can zoom in a bit more for you then, can't I?
Make me not look completely useless. I'll steal.
I'm testing you out here. You see, you didn't know that, did you? This is your final test.
Is it? So I think, I'll give a couple seconds if anyone in chat wants to help me.
Okay.
Signs I can see.
If anybody else wants to help him out with some of the signs that they can see, then just type it in the comment section and let us know.
Really nice.
So yeah, I mean, you know, there's several key things I think when you start learning dermoscopy. One is pigmented network and your fissures and ridges to decide SEB-K or melanocytic, and then little pink papules. I call them PPPs, people with a pink papule problem, and the most common one on the face is either intradermal nevi, you know, with a hard mixture type, you know, a BCC or a sebaceous gland hyperplasia. And that would probably cover 9 out of 10 of these things.
Sure.
Probably so 9 out of 10. Come on then.
I think we've got arborizing vessels here, and I think you can see crossing the midline.
Yeah, so it's the pattern of them as well. But so you've got a trunk here going to medium, going to fine, and even finer. So I think that's a genuine arborizing. Plus, can you see all these little fine vessels?
Oh yes, yeah.
I was talking to the Professor Cliff, and in his presentation, he was saying one of the reasons you see these so clear is not just the fact they're more superficial and closer to you compared to these deeper dermal vessels which are out of focus, but also because the stroma just highlights them very nicely and acts as a kind of background for them really nicely.
An ovoid nest, you'd say, right? Directly.
Well, what do you think of that then?
Potentially, but
so you have little small dots of pigment, then you have globules, and then if they are, I can't remember, there's a certain size, then you'd call them ovoid nests. I'd probably call that a globule, but that does make you concerned. What color would you call that?
Brown.
Yeah, so it's kind of like a bluey grey brown, isn't it? And I think with dermoscopy, it's understanding the colors. So, you know, the way those two bits are together makes me worried that you won't get anything like that in a sebaceous gland hyperplasia. So you've got to think really, and these are obviously the air bubbles and things. What about these white stuff? What about this white stuff? What do you reckon?
Which bit? Sorry,
the white bits here.
Zoom in a bit on them.
Can you see those white fluffy bits? Let me bring up the other one. Let me bring up. So that was polarized light. So what I'm going to do now is I'm going to show you the non-polarized. And
so what was his story? Did he remember it changing at all?
He didn't know it was there.
Okay.
He came with something else, which I've actually referred him for. So where are those white fluffy things?
They sort of disappear. And we've got some rosette signs up top right. Kind of 1 o'clock.
Up here.
Bit to the left.
Maybe. So yeah, the white bits have gone, and this is non-polarized. So those are shiny white structures, and they tend to be the blot and strand variety in BCCs. And then maybe that's a May globule. You know, you see them on both. So, you know, we've got several things there. You know, you haven't got the popcorn of a sebaceous gland hyperplasia. It's not an intradermal nevus, you know, and that's a BCC. High risk, low risk, what do you think?
That's a good question. I was going to ask you. I mean, it's on the forehead, so I guess technically, probably not high risk because it's not near the eyes. It's not on the nose. So probably low risk.
So it is a low risk one, yeah. And I've seen these double in size, so I watched them very carefully. So I referred him, explaining how long it's going to take.
Yeah.
I actually referred him 2-week wait because of something else on the side of his head that looked like an SCC. And I said, oh, by the way, he's got this PCC on his forehead. So hopefully we'll get them both treated together, which would be really cool, etc. So hi to people who just joined us. That's nice to have you with us. Feel free to put your name and comment and say hi and just chip in. We're just going through some cases and testing Javier.
Yes, please down. Help me.
So, Javier, what's the next one up? What did you think you're most struggling with in dermoscopy at the moment? Where are you at, you think, in you?
I think Ks are, you know, as you call them, the chameleon, and I think they're probably the one I'm still not brilliant at, you know, and it's work in progress.
Right. Okay. So again, this is a lady who came worried about this thing on the side of her head. It's not brilliantly focused, I'm afraid, but you can get an idea of it. And it's been there probably about 9-12 months, something like that. No symptoms.
How old is she?
She's probably 60, something like that. No skin cancers before. What are you thinking?
I mean, macroscopically looks a bit like a Seb K.
Yeah, I mean, you almost want to get your finger and scratch it, don't you? I think that's one of the reasons why telederm isn't brilliant, because, you know, dermoscopy is also about the history and also about how does it feel, you know, is there a pinch test and all this sort of stuff. So you lose all that in just with a photograph, don't you? Well, let me show you the picture then on dermoscopy, which I think, and I want you to explain this picture to me. And I mean, it's not, you know, it's not outrageous, but, you know, tell me what's going on here.
Oh, nice. So yeah, you've got kind of fissures and ridges, right? Yeah. We've got, I mean, what I'd say is a beautiful Seb K.
Yeah.
I'd be intrigued to see.
You see, you're in trouble now. When you say beautiful to something like that, I mean, A, it means you're a dermoscopist, and B, it is a little bit worrying. You know that, don't you, mate? Okay, yeah, go on. Yeah, so why is the funny? There's a funny color there. Why is that?
Keratin, is it? I'm not sure.
I like the little fingers at the bottom. Do you like the little fingers of keratin? Yeah. Beautifully well demarcated, fissures and ridges pattern, and because it's hyperkeratotic, so this is quite hyperkeratotic, and that covers up all the vessels and all the milia, so you're not going to see those. But she's actually got foundation on.
Oh, right.
So it's not, you know, it's not due to tanning or anything like that. And they come in and you know, the number of ladies have smeared with foundation, and you try and take it off, but you can't take it all off because it gets into the fissures and ridges. So I just wanted to see if, no,
I
on with that, you know,
bit to mind, but you're right. And, you know, it's, I think I showed a picture where there was one where, you know, it looked like Navi, and it was just chocolate ice cream on a man.
Right. So, have you been on any courses at all? Have you been on any courses at all?
I guess the way I see it is I've been on kind of your course. So I've used your and your kind of workbook.
Yeah.
Like as a you know, professional course.
Yeah.
And I've kind of been cementing.
I was talking to Dr. Evans in the practice, and he said to me, "Oh, should I go on a course?" And he just started. And I said, "Look, just look at lots of patients. You know, do a little bit of reading. Spend 6 months, because then when you go on a course, you know, then actually you're going to appreciate it more because you've got a bit of basic core knowledge." 100%. And he actually came back to me after one of the primary care dermoscopy, the beginner's course. He said, "Andy, you're dead right. You know, I already knew a little bit, and that means I could absorb it. Because if you go straight on a course, it's all new, and you're like a rabbit in headlights because it's a different language and everything, isn't it?" So, you know, having that little bit. Right. So here's your next tester then. So this is on a thigh, upper thigh, and the guy came to me and said, "Oh, I've noticed this the last few months. No pain, not growing. What do you think? What do you think?"
I think that's a spot diagnosis, dermatofibroma.
Yeah, see, you're getting there. Why do you say that? Come on. Why do you say that?
Got that kind of uniformed border. The color looks quite, you know, browner on the outside. It looks slightly whiter towards the middle. It looks, although it's obviously a picture, it looks pinch positive. It just has that look where I think I could pinch that, and I think I'd get a positive pinch test.
I mean, there is a color to dermatofibromas, isn't there?
Yeah.
You know what I mean? And it's one of those ones where you really want to touch it to try that pinch test on it. Yeah. Okay. Well, look, let me put up the video for you then.
Yeah. seeing.
It's a quick video because I didn't do a long one on this, but I think it'll tell us what we need to do. So
Quite good. Any story with this guy? Did he remember any injury?
he doesn't, and they don't, do they? Most are on the legs, but you can see them on the trunk and elsewhere. I've never seen a dermatofibroma on the face. It tends to be limbs and stuff like that.
Sure.
So already you can see some white lines, can't you? But just watch this then. Look. Yeah, so on and off.
In and out, yeah.
Yeah, so I mean, this is where a hybrid dermoscope, people watching, hybrid dermoscopy is really going to help you understanding shiny white structures and these lines.
Don't go for just kind of one or the other. So I think you do need to fully commit to a hybrid dermoscopy. If you're going to do it.
I mean, you can, when I was starting out wondering what to invest in, these days, particularly the Ibulu, you can get a fairly reasonable hybrid dermoscope. Otherwise, you're going to miss stuff like this. You're going to get bang, polarized, non-polarized, and that really just helps you understand that those are shiny white structures. Now, these are short white lines. What can that be? What's the differential diagnosis with dermatofibromas?
I guess you could say potentially a melanoma.
Why?
Because you've got a lot of these shiny white structures, and that can be a sinister feature. So I guess that's something that
very important. Absolutely, and this is quite symmetrical. The history is quite good. It was pinch test positive, and around the edges, the reason is you can think they're, you've got this fine, often pigment network pattern. You can't see here; it's more homogeneous, and there are about 15 different, or so. It depends which article you read. Some say 22 different types of dermatofibromas. I mean, you had one that was a classic, and when you see that classic one with a beautiful white center and things, it is lovely when you see it. And as time goes on, you build your repertoire of what you're happy with. These things shouldn't be growing; they need to be hard. And they're pretty stable when you see them. And then you can just reassure people. Do you treat them?
No, I mean, but when you say treatment, what would you even do? I guess cut them out?
Yeah, they don't freeze well because they're already scarring. This is from collagen. They don't freeze. If you're going to cut them out, you're going to have a scar bigger than that.
I'm about to say.
So I always tell people I'm going to make a right mess of you if I cut it out. And the only reason to cut it out is?
Pain.
If you're not sure of the diagnosis.
Okay.
Yeah. So how many, and as I've been doing this course, thinking about, what's important in my journey over the last 10 years doing dermoscopy and primary care, what are the important things? One of the things that I've really thought about, really took me to the next level, is the number of patients I decided I needed to see. So how many people do you think you are looking at per week at the moment?
At minimum 6 with and I'm really fortunate where I work is awesome. I work with fantastic people, and I had that discussion where I said, I'm training up in this skill. I think it's going to benefit us all. So I have dedicated slots where I teach just skin stuff, and so I've started to re-audit our 2-week wait, and already I can see a higher conversion rate of 2-week rate referrals.
Really,
which is great.
Yeah, that's awesome. Yeah, I mean, I think as a GP dermoscopist, all the time scanning people's faces and arms and legs when you're doing something else, because there's a study in France that showed almost half of all melanomas were picked up by chance. And Hanan picked up one, our F2, a melanoma on the shoulder, which I did a short case on, just because she was looking. So I think 6 patients. I probably only see about 10 because I do it every couple of weeks. That are officially booked in with me, but all the time I'm looking, and looking at intradermal nevus and building up that repertoire. So what do you think of this then?
Oh, I was just about to say, because I actively say that I'm interested in skin. What's quite nice is people want to show me other skin stuff as well, ad hoc in between that. So you're always developing. But so we've got this foot
there. So this is an 8-year-old who came with 5 months of itch, and had been to various other doctors, and they really didn't know what to do. And they'd thrown some scabies treatment at her, and it hadn't worked. So what you need to do is what?
So you said that they gave scabies treatment, but it didn't work.
They did, and it didn't work, and that's sometimes what happens. And the key thing is you've got to get a diagnosis. So
sure, let's have a look.
What do you see here then, Javier?
Oh yeah, lovely. We can see a brilliant, not the great use of words, but a nice burrow. It's the kind of the pattern of it is, as you'd say, it's not kind of human made. So, it's not kind of excoriation. Is that feces? Would you say? Those little dots and things. Are they?
You can get the black dots and the eggs as well. This is quite short. I mean, they are about 10 to 12 millimeters. Any longer than that, and I get a little suspicious. But look at that curve, and ultraviolet light. Here you've got the little delta, which you don't.
Sure.
You don't see the body there so much, do you? But when you get the ultraviolet light on, the body shows up, and it's slightly greenish, a little green tinge. So I think that's really great. And here's another one. So when I looked at her foot, she had about 4 of these things.
Blimey.
And I looked around. She had a couple on her hands as well. And I thought, you have not been properly treated, madam. And you've still got live scabies there. So we did the whole family again because there was 4 of them, and that's the thing.
So just before you go on, I think I asked you this before, but is there a way you can tell between a kind of live scabies and a dead scabies?
Yeah, well, if you see its legs up in the air going like that,
okay.
Live. No, I don't think you can see them munching away at you. I think it's a horrible thought, isn't it? These things munching away at you.
So is it possible?
You can see the difference there.
Is there a possibility that this could have been treated then?
Yeah. So permethrin or whatever should kill the mite, but then it has to be shed with the skin, which is 20 to 40 days, which is why it takes a while for the itch to disappear. Sure. And I've seen so many. I mean, how many have you seen this year? I've seen lots of scabies.
It's probably the same person, I think.
They came from your practice.
Yeah.
So I must have seen about 10. I mean, this year has been, anything that's itched, and I don't know what it is, and it's chronic. I'm thinking I've got to check for scabies.
I think that's what about scabies is, though. The exposure to kind of symptoms. It's sometimes 6 months. So typically, I don't think they make that link straight away.
Yeah, and it's important to treat the whole family. I didn't appreciate that early on in my career. It's a bit of a faff, isn't it? Saying to them, look, we've got to treat the whole family, because often they're asymptomatic, and you can get it just going from one family member to another. And I had one where the young lady was, in a bed sit down in London as well as a family at home. We had to treat both. And it's not cheap either if you buy it over the counter. So you've got all these issues to deal with. Right. So tell me what you think of this. I selected this one because it's something that early on in my career I really struggled with. So have a little look at this video and see what you think. Again, this is a guy kind of like in his 70s, and he's got this thing that's on his back and it's irritating him. And he was worried about it. So you've got that up there. So let me just jump to the good old dermoscopy stuff. So, initially, what can you see there?
I think you've got fissures and ridges on kind of lateral side on the left.
Yeah.
The central bit that I assume is more irritation. I wonder if he's been scratching it.
Okay. So you've got the nice fissures and ridges pattern again, well demarcated here. And I used to get confused with this. I used to think, what's going on here?
Sure.
And as you zoom in, again, you've got the comedo-like openings with the darker, which would probably show up very nicely on the ultraviolet light. But then that pink bit used to worry me, but it doesn't anymore. So there you go. Nice bit of ultraviolet light showing all those little things there. So, I think I zoom in. Let's see if I zoom in. Let's have a little look around here. See, look, all the nice little fissures and ridges, beautiful fissures and ridges and pattern, switching from one to the other. And then you get to this bit here, and you've got the little vessels here and the little fingers. But, this is just where the top's been blown off. It is just an irritated ZK. And if it's all irritated, it can all look like that.
Sure.
And if you get hairpin vessels, you worry about squamous cell cancer and things. But for something like this now, I've seen so many of them that I think, yeah, I know what it is. Yeah, don't worry. You know, you can always put a bit of hydrocortisone and protect it, and it will kind of like heal. But I can't remember if we treated that one or not. But that's a nice little Seb-K, isn't it? Nice square shape, well demarcated. But it's an irritated Seb-K, and that's something always to bear in mind. So, what do you think of the channel so far, Harvey? Have you watched many of the videos?
No, it's my first time meeting you, actually. So, with them, your personality comes out through, and it's been really helpful for my learning. I think what's been quite nice is it's a lot to take in to begin with. So, you know, I've had to go back to videos, and once I've seen cases a few times, it's been helpful to kind of remind myself that, oh yeah, I should be looking out for, you know, not crossing the midline, X, Y, or Z.
Yeah, and it gives you a place to start, hopefully. So this is fairly soft. This is on the neck of someone in their 60s. As you can see, it's probably about 5 millimeters. What do you reckon?
Is it possible to zoom in a little bit more? Okay. So we've got, I think we've got potentially arborizing vessels then. They look like they're crossing the midline.
Yep.
So I think this is a BCC and nodular.
It would be because it's raised. Yeah. If
it was. I mean,
anybody want to comment on this?
The other thing I was thinking, is it an intradermal nevi?
Okay.
But it's the vessels. I mean, would you say they're crossing the midline?
They are. Remember, vessels are the least useful.
Okay.
Vessels are the least useful. So you tend to go on other things first. Obviously, the history helps. So this is really quite stable. It's not grown a lot recently. And when you put your finger on it, it is soft.
Okay. Yeah. So that's
more. But after a while, the feeling of that thickness in the skin that you get BCC is really, really useful.
Yeah.
If you also, there's no erosions,
no
globules, there's nothing else, and the surface is actually really quite smooth.
Sure.
And you know that we talk about hairpin vessels. Maybe that's a hairpin vessel there, and these are slightly maybe out of focus. And if you press it, they come and go. But so hairpin vessels you do get within intradermal nevi, and this is actually a straightforward intradermal nevus.
Okay. I mean, you're right. I think that, you know, it's the whole picture, isn't it? You know, you can't just look at that.
And it's seeing lots of them. I mean, I think that's the thing, you know, just seeing, let's, you know, look at lots of them. This is on the same person. This is the scalp now. And I used to worry about these things. These are quite soft, and these have been slowly growing. What do you think of them? Nice and pink, soft hair coming out of them.
Oh.
Yeah. That's an official dermoscopic sign, by the way.
Yeah. We've got hair out of them, so that's a good sign.
Okay, let me show you the dermoscopy then.
Yeah.
They were both very similar. What do you think of this one?
So, yeah, we can see hair follicles.
Yeah. And hair follicles is a good sign in that you haven't got the dermal destruction that goes with, you know, but you can occasionally get hair follicles still in different tumors and stuff. But look, I mean, they're all over, aren't they? Which is kind of like reassuring. So you got just some white stroma, haven't you?
Yeah.
And again, it's soft. It's been slowly growing. And these are more short little vessels. I mean, look at that one. That would be your kind of like your classic comma vessel.
Yeah.
Here, a little comma vessel. So this is another intradermal nevus.
Sure.
But it's interesting, you know, on the scalp, I think partly because the blood supply is so huge.
Right.
That, you know, you do get these larger, soft, bulky intradermal nevi and things. So yeah, so I think, you know,
that's a good picture. No, it's really helpful. I think macroscopically it can be a bit daunting, and then when you look at a lot of reassuring features, you don't think, okay, well, I'm not worried.
Yeah. Here's another scalp, someone else. Again, not the best focused. This is more of a plaque, and it's a little bit rough surfaced. I mean, you can see it's about 12 millimeters, about the size of my thumbnail. Again, slowly growing, maybe the keratin. You know, it could be a patch of psoriasis maybe, but there weren't any other patches, and this has been there stable for quite a while, slowly growing. And the dermoscopy, I will show you. Here we go. You know, because you look at something like that, and there's several things it could be, and that's the great thing I like about dermoscopy. You know, when you look at something with your naked eye, you can't like decide what you think it is, might be, and then you look at use the dermoscopic image to try and confirm and deny what it is. So have a look at that now. What do you think? Any thoughts, anybody? Anybody can chime in if you wish.
Is it potentially a hemangioma?
Hemangioma would have lacunes and stuff like that.
Ooh.
So let's go through it bit by bit then.
Yeah.
So it's pretty symmetrical, isn't it? It's like a pizza. If you took a slice, it's got something in everything, hasn't it?
Yeah.
In every bit. Again, you've got the hair follicles again in, which is pretty reassuring. What are these dark bits here? What do you think those are?
I'm not sure. Is it melanin? Can you zoom in at all?
Okay, so I can't zoom in. I can switch to the dermoscopic image if you like. Let's do that. Let's do it because I can zoom into it now. Okay, let's throw that on there. Here we go. So yeah, so that could be melanin, but what sort of color is this here? What sort of color is that?
Where, sorry?
Down around here. What sort of color is that?
I mean, initially it looked a bit reddy brown.
Okay, so this is a reddy brown color, and so you think maybe it's an erosion there and things like that, but I think that's hemorrhage.
Yes, yeah.
So that's hemorrhage in some of these vessels here, and with the vessels, what do you notice about? How would you describe those vessels, which are pretty much the same throughout?
Yeah. Can you zoom in on one again? Sorry, my eyesight's not what it used to be.
What do you think?
I think, I'd say maybe hairpin.
Yeah, so you've got some are dot.
Yeah.
Some are kind of almost coiled, and you've probably got a few like these ones here, which are hairpin.
Yeah.
And hairpin vessels speak of keratinizing. So actually scaly 6, you know, your wart, your seb-K, squamous cell cancer and all those sorts of things. But there's nothing here of cancer really.
No.
But also note, has it got a white halo around it, do you think?
Yes.
Yeah. So this, if I took that off, that's going to be a seb-K.
Okay, sure.
Yeah, it could be a wart, but at that age with that pattern, and this is just a bit of trauma on the surface, which can confuse you. So again, this is very common. You'll see on the scalp something like this with little hairpin vessels. Look for the halos. You know, if they're isolated, that you know you can get hairpin vessels in almost anything. But again, that's a seb-K on the scalp. You know, don't worry, don't pass go. So Javier, we're kind of like folks coming to the end. If people have got any questions, that's cool. Am I going to show any of yours, Javier? What do you reckon?
I think the dermatofibroma one. I think it's you know, chef's kiss.
Okay. Yeah. Let me see if I've got it on here then. Let me put that through onto there then. I mean, have you got any other particular questions, Harvey?
Yeah, I guess with that seb-K, you know, in your kind of previous examples, you've seen kind of hyperkeratosis. So, you know, the color is kind of darker. Well, that was great. And I think potentially it's just kind of the video medium. So I guess that's a learning point as well. But it looked quite red. And, you know, like red's not really what I associate with seb-Ks initially. You know, obviously when you look deeper and you look at the kind of the picture, you can see kind of more features of seb-K. But initial kind of, you know, I don't know about you, but sometimes, and I guess that's still my learning, but there's kind of a gut instant. I'm like, okay, this is fitting X, Y, or Z. And then I'm looking for things that support that.
Yeah, no, I think, again, it's just looking at lots of them and getting used to them. Right, this is yours. Explain what I see.
So we've got a lovely kind of shiny white structure in the middle with kind of finger-like kind of going out with the changing on the peripheries as well.
Yeah, and classically, it's lighter than the surrounding skin.
Oh, yes. Hair follicles.
Yep. Yeah, and this has almost got that faint pigment network, which makes you think it might be melanocytic, which is why. But with it being so symmetrical, and was it pinch positive?
It was, yes.
Yeah, so being pinch positive again is reassuring, and these things are nice and stable. So that's a beautifully symmetrical dermatofibroma. Excellent. And when you see one of those, you do treasure it, because they're not always as classic as that.
Yeah.
It's always nice. Excellent. Okay, thanks, Javier. Is that all right? Anybody got any final questions they're put up before we put the roles? Thank you for joining us. And anybody who's joining us later on, look out for the next one, which we might do in a month's time. I'm going to get professors and other people involved and ask them some tricky questions. So you're the inaugural person, Javier. How's that?
I'm very lucky. I got a cup for payment.
Absolutely, very important. Limited edition. Not many of those around. No, excellent.
Right now, so.
Well, thanks for playing. Thanks for playing along.
Oh, my pleasure. Thank you so much.
And keep up the work and good work. You're very welcome, David. Thanks for joining us. And if you've got any questions, ask them or post them below. Now then, I'm going to see if I can do a little outro. I hope that's been useful to everybody. But thanks. And the video is going to be posted up onto the site in a second or two. So thank you.